Hi, everyone, and welcome to the Texas Epidemic Public Health Institution's Infection Prevention Series, Module 205, with concentration on hemodialysis. This module will briefly introduce hemodialysis. We'll talk specifically about monitoring water in dialysis department and what central line associated bloodstream infection or CLABSI risk that pose to these patients. I'm going to mainly focus on the dialysis water system today. Feel free to post any questions that you have throughout the presentation through the chat, and we will answer them at the end. After the lecture is concluded, we will be doing a knowledge check, so we encourage all of you to scan the QR code on the screen to participate, to check your knowledge and kind of see how much information that you have learned through this presentation. At the conclusion of the webinar, you will see another QR code on the screen that will be towards a short post-module evaluation survey that we are asking all of you to complete. It would be great if you could complete this. It really helps us provide feedback of how we can make these lecture series better and provide you with more information that you are seeking. This lecture has been approved for 1 hour of a CPH continuing education credit, and instructions on how to complete your CE will be at the end. This lecture is being recorded, and within a week, all participants will receive a copy of the slide deck and a link to the recording of this lecture. So the module will be posted, you will receive a link to the slide deck, and then also to the recording. So before we start talking about today's topic of hemodialysis, I want to take a moment just to briefly tell you what TEPI is. TEPI, or the Texas Epidemic Public Health Institute, is a state organization that is housed, sorry about that, is a state organization that's housed at UT Health School of Public Health here in Houston. And our mission is to keep Texans safe and the economy strong by strengthening and creating new service lines and resiliency within the Texas community to respond to the next infectious disease outbreak. My name is Kayla Rush, and I will be your presenter today. I'm an infection prevention practitioner who has had the opportunity to work in acute care hospitals here in Texas, long-term and nursing home facilities in New York, and then back into acute care in California before I returned to UT Health to conduct my PhD in epidemiology with my focus on infection prevention and control. So today's learning objectives, as I mentioned before, we're going to briefly describe and explain kind of the overview of hemodialysis, talk about and describe monitoring practices, specifically in the water component, looking at your water system, and then lastly, talk about the hemodialysis risks that pose to the patient that have central line associated bloodstream infections. So what is dialysis exactly? So dialysis is a renal replacement therapy that are procedures that really help individuals that may have been affected by an illness or a chronic condition really remove metabolic waste throughout their bodies and through their blood through diffusion and different pressure gradients. Individuals can be on dialysis for many reasons, such as an infection, an injury, or they might be on crack, or they might be undergoing dialysis chronically due to chronic kidney failures and other things. And the range of treatment options for people that are undergoing dialysis is really dependent on their specific diagnosis, if this is a chronic or an infectious event, and it can really dictate how many times a week that they are undergoing dialysis. Other additional things that might play into factor about how long and the different treatment options for your dialysis is such as age, gender, race and other health problems. Specifically, the National Kidney Association says that you can be on dialysis for many years effectively, or it might be intermittently, as I've mentioned. So dialysis is broken down into two main types. We have hemodialysis and peritoneal dialysis. So hemodialysis removes toxins, electrolytes, and fluids by circulating through the patient's blood using a hemodialyser, compared to peritoneal dialysis removes toxins, electrolytes, and fluids by diffusion through a peritoneal membrane, which is one of the membranes within your abdominal cavity. So that if you are undergoing peritoneal dialysis, you have a catheter placed throughout the abdomen for access, and you have repeated infusions and drainage of the dilate. For today's topic, we're going to mainly focus on hemodialysis and the different components that is involved in that. So just to give you some background on the history of dialysis and how it came to be, Thomas Graham is known to be or regarded as the father of modern dialysis. He used osmosis to separate particulates and remove water through a paramembrane. Although he didn't apply this method directly to medicine, his work really laid the foundation for artificial kidney and really conducting this in patients. Next, then we have George Haas, which is performed the first dialysis procedure on humans in 1924, but was very unsuccessful. He tried seven different patients. However, none were able to survive the procedure, but most likely due to other critical conditions and treatments that they were currently undergoing. He developed the Haas dilator, and then he also started using an anticoagulant, Heroin, which is also our anticoagulant that a lot of the times that back in the day they got from leeches, that enzyme that they secrete. And then later switched to heparin to improve effectiveness, and then also for sterilization process and standardizing of making sure that the specific dose was appropriate and that there was a standard concentration given. And then lastly, we have William Croft, and he was the first individual to successfully complete a dialysis treatment on human patients in 1945. He helped develop and performed the rotating drum kidney, or the RDK, and this kind of used many membranous tubes made up of cellophane and electrolyte solution that is also used as the dilate. And this really helped the advancement in artificial kidneys, lungs, heart, and open heart surgery. So this is one of those hemodialysis or dialysers that I was just mentioning. And hemodialysis is performed using a specific machine that has its internal fluid pathways that mix the dilate component, which is composed of water, bicarbonate, and acetate, that passes through the dilate pathway to the hemodialysis and then discarded into the drain. So it goes through this filter, as you see, that has the blood inlet and the different fibers, and then the blood outlet. So it goes through the solution, mixing it appropriate, and then it passes through. And then during this process, we use a highly purified water or sterile water, or called product water, to really perform this, making sure that we're removing the appropriate toxins in our blood and then circulating black clean blood. So if you think of it like hemodialysis is a way, since our kidneys are not functioning appropriately or they need a little bit of help to filter out some of our toxins and our byproducts throughout our blood, this system is taking the pressure off the kidney so that it can heal if we're in an infectious intermittent state, or for a chronic patient, such as waiting for a kidney transplant to be developed or received, that we can still be filtering our blood appropriately. And I want to highlight that this using a certain type of purified water is critical to this. It's one of those things that saying good input or good materials in give good materials out. So if you're using contaminated water, or if your process in your facility has been compromised, you're going to have a whole slew of problems, specifically with cross-contamination, either in ionic charges being not great for patients, bacteria being introduced, or other type of organic or inorganic compounds, such as your calcium level being off, your magnesium level being off, your ionization being off. So there's a huge process that goes through the water collection and purification process. And they specifically, the organization that really monitors and puts the standards is our Association for Advancement of Medical Instruments, or AMI, put our water standard purification. So they put the national standards. States have the option to put stronger standards in place or to follow AMI guidelines, and we'll look at them specifically later. What our Texas guidelines are. Most big hemodialysis centers have water treatment systems or room, which have the water softener, our carbon filters, our particulate filters, our reverse osmosis, our deionization filters, and our ultra filters with or without UV. And we're going to talk about each of those. So that room looks like this. So in your facility, if you have a specific hemodialysis unit, not just the portable dialysis machines, but an actual unit, when you go into that area, you should see a room that has all these filters in it. And if you're not sure, I encourage you to go to that department and specifically ask where your filtration room is. It's really important to make sure that, yes, you're auditing the area, but you're also making sure that you're looking at your tank system, and you're making sure that the IFUs, or instruction for use manuals for each filter system, are being used, and that you can speak to your process. So each different component we are going to talk about in detail from the left going on to the right. So the first part of the system is our gauges, which really helps prevent backflow. And this backflow pressure can really occur when there's a water main break or an unexpected high demand for water that reduces the pressure, which you might think, oh, our water mains don't break, or when does this happen? Think about any of the flooding or rain events or hurricane events that Texas is very prone to. So during mass flooding, a lot of rain, there can be a different pressure demand with the water because of how much water, if there's flooding in the streets, going into our third-party water system, that will really change the pressure. So this gauge really helps make sure that it's within appropriate limits. If you're never sure, there's always on the gauge itself, there's the red, yellow, and green zone. You always want to be in the green zone. And if you're not sure, definitely ask your engineering or facilities engineer to really help and go point this out to you. They should be able to explain this process to you if you're new to dialysis in this realm, and then kind of some of these engineering controls. Definitely go ask your collaborator and a multidisciplinary teammate of, hey, can you tell me the threshold when I am auditing this? Is this within limits? Especially when you're going down and auditing the dialysis room, definitely check on the pressure gauge. That's going to be your first step of the process. So you want to make sure it's within the proper zone. If it's not, and there's a change in pressure, that can really cause cross-contamination, and it can prevent and cause chemicals to go into our water system that we're using on our patients. So next, after our pressure gauges, we have our water softeners. So there are these two big filters that you see. The ST on the diagram is the sample port. So at each system, after each area in this diagram and in your room that you are seeing, you should see little sample ports that you should be able to access and provide and pull a specific sample out. And this is really important when you're switching out your filtration tanks, making sure that you're within limits that you want to make sure that you're taking after at the end, not through the whole system, but if you're switching out like your water softener filters at this point, that you want to be sampling after that to make sure that it has been put in correctly, it's fitting right, there's no obstruction, and it's doing the job that it's supposed to do. The water softener's main job is to exchange our calcium and magnesium ions from our incoming water with our sodium items. So at the end of, you'll have your two tanks, one or two tanks, and then you'll see your brine tank, which is pictured here. And it is a big tank of sodium. You should be able to pull off that lid and see the specific sodium in there. When you pull off that lid and you're in that room and there is not sodium, that is a problem, and you need to be making sure that you're letting your engineering folks in your dialysis control filter system, people know like, hey, my tank is really low. After you change out or add more sodium to the different tanks, you want to make sure that you're testing to make sure that there's within specific limits. So you're not having too much sodium being produced. And during exchange or regenerating these tanks, the individuals cannot be hooked up to the dialysis unit at the time. So anytime that you're working on your water system, you need to make sure that it is non-operational and there's no patients hooked up on it, just in case that you put in a filter, or there's another issue that you experience that you're not accidentally causing exposure on inappropriate levels to a specific organism or a certain chemical. For this, in this step, that would be sodium to patients, because that can cause them hypernatremia and other issues as well. So after your filters are changed, you always want to test it as it shows here through that sample port, which is the SP on the diagram. So after the water softener, then we have our carbon filter, which is our carbon filter then removes a different chemical, which is our chlorine and our chloramine and other organic material from the plies. So in this stage, there is always a risk of cross-contamination and inadequate disinfection based on the granular columns within these filters. So you want to make sure that these filters are changed appropriately according to the IFUs, the instruction for use. If that's a 30, 60, 90 day, if it's that many dialysis patient treatments that are going on, if there's a certain level of water that's being output. Every system is different, and in that IFUs, it will specifically tell you what the regulation is for best practice for this specific filter. So you want to make sure that you have, in all the stages of this water treatment, each IFU for the filter individually, and making sure that they are changed and being adequately processed and monitored accordingly. So now, after you change out your filters, you want to make sure that you're taking again from the sample port, which is at the end, and this should be conducted at least 4 hours while patients undergo hemodialysis. So the first system, when we're exchanging out the sodium in our water softeners, we cannot be using it when it's hooked up with patients. In this part, when we're sampling it, it can be hooked up, and it should be at least monitored and samples pulled every 4 hours. And then the system should be at least operating for 15 minutes. So just to have an appropriate, not clean, but a good quality sample, you always want to make sure your system is running for at least 15 minutes before sampling, so it gets things that are maybe sitting in there and kind of through all the different filters, that you can get a true, reliable, good test. And then as it's mentions here, that these testing should be performed after the first carbon tank. So if you have a series of carbon tanks such as this, you always want to take from the sample port from the first one, because that's more of a true sample within 15 minutes. And then while at least every 4 hours while someone is undergoing hemodialysis. Next, in some facilities, then we have our particular sediment filters, and that really helps remove different sediment that from the incoming water that could really damage or clog our water system. Again, this area or this filter reduces the risk of cross-contamination through different bacteremia. And then these particular filters should be monitored if there's pressure drops throughout the filter. So when you're having a water event, flooding, or a hurricane or a downpour, if you have lost pressure through your water system, you want to make sure that you're monitoring the system as a whole and then in each individual component, because when the pressure drops, that means the rate of filtration, that normal rate, has been affected. And so we are not cleaning things and then the water is not going out the specific volume, time and flow through the different filters. So that increases our risk of potentially having an issue, causing a clog, causing cross contamination to our patients. And then these filters should be replaced or disinfected according to the IFUs, as I've mentioned before. You need to make sure that you are following that, because only that, those specific instructions have been tested and proved for disinfecting these filters appropriately. Next, we have our reverse osmosis, our RO system, which uses osmotic and hydrostatic pressures over semipermeable membranes to remove ions and inorganic materials. So depending on your specific RO system, your filters will be gauged for about 90 to 99% effective of removing electrolytes, bacteremia, and endotoxins. And that number is based specifically on your types of filters within your system, your specific RO system. So that information is always listed in your instructions for use, your IFU manuals, for your specific system. So that's why it's so important to make sure that you have all of the IFUs for each specific filter system within your dialysis department, so that you know what the specific rates are, how often you need to change them, to really reduce risk of exposure to cross-contamination to our patients. And the quality is directly dependent on the specific type of membrane that you have. Each different company has different types of membranes within their filter systems, so that's where that variation is. Next, then you see here are these little deionizers. They're usually like resin bead columns, and they're smaller. There's usually a set of 3, and they do ion exchange. So they do not remove any type of bacteria or endotoxin, specifically your ion exchange, of making sure that it's the appropriate ionic charge and that we are not overcharging our solution to cause specific issues to our patients. They are used as a backup to the RO systems, which removes a lot of the bacterial, the organic and inorganic material. This is now just our chemistry charging ions, making sure that is the appropriate charge to be then used through the system that then goes into the person. And then lastly, we have our ultra filters. So you can have ultra filters with or without UV light, and that will be really dependent on your specific system that you have in your facility. So again, making sure that you are looking at your instructions for use, so that during audit season or when Joint Commission or CMS is there and they're in your dialysis department and they're specifically asking you and they're asking the staff, what type of filtration system do you have? Are you using UV light or not? You can specifically state with confidence, yes, we are, or no, we are not, and then provide them with the instruction for use manual on your specific systems. The ultra filter should be your last specific component in your distribution loop before it hits the patient. So we go through all the different process, and then this one is our last final check to make sure that we have removed all bacteria and endotoxins before hitting into our patients. Just because you have ultra filtration with or without UV light, it does not eliminate the need to monitor our bacteria and endotoxin. So throughout the system, there's multiple checks of like different components doing different things. You have your removing your magnesium, adding sodium, removing chlorine, organic material, inorganic material, endotoxin testing, and bacteria. But you still need to then confirm with specific testing criteria, which is set by AAMI and then within our state. And these are the specific criteria is listed here, and I have a link in the slide deck that you can refer back. Is the Texas regulation specifically on water treatment within dialysis departments within our system. So it should, as the regulation number 16 states, that it's continuously monitored. It should be visually and audibly with alarms. So when you go into your dialysis room, you should be able to see with certain types of alarms, with the sounds. These should be notifications, either to most of the time, it's your facilities manager that is alerted by this, but definitely ask what your process is within your specific facility and who is getting these alerts and these alarms. And then specifically that, we want to make sure that we are monitoring and collecting testing at the last distribution point throughout the dialysis process. And specifically with our biological testing, it is a requirement. So it is a regulation we need to conduct, and it's routinely done, which for the Texas and any guidelines, it's at least done monthly. And then here's our specific standards that in a nice little graph, which I have a link to the specific AMI guidelines, which is nice because it can give you your bacterial for your water, your dilate, your endotoxin test, and then your specific guidelines here. So you need less than 200 CFUs, which is coliforming units over your milligrams. And then it also gives you your level of action. So you can have a lower level of your institution, like for an example, for the typical action level, if you, instead of 50 CFUs per milliliter for the bacterial water dilate, if your organization has said 5 or 10, that is acceptable. You always want to, you can always go higher than what is expected, but you cannot, with regulations, you have to be following the minimum standard, which are these specific concentrations at these levels. So now that we've talked about water, so we've talked about the water basically going up into it hits us. So now we are specifically talking about, we're going to switch gears and talk about our central line associated bloodstream infection with these specific patients and what that looks like and how to monitor them effectively. So first, hemodialysis. It's a vascular access, as we've talked about, which are removing different types of things, and there is a fluid exchange. Just because you are receiving, you or your patient is receiving dialysis does not necessarily mean that they are eligible for the National Healthcare Safety Network, NHSN, CLABSI, or VASC definition. So there's specifically excluded lines. So it's really important when you are doing your culture surveillance and your line surveillance that a proper documentation is done, and your bedside staff is specifically documented if they are giving access via fistula versus a graft, or if it's a temporary vascular device, which is more for our intermittent infectious or maybe injury to the kidney, and that we're giving a little bit of break, but they're not a chronic dialysis patient. So usually fistulas and grafts are given for chronic dialysis and they are excluded, but the temporary lines, NHSN does put them at eligible for a central line associated bloodstream event. And most likely it is going to be an intrajugular or subclavian line, which IJs, intrajugular lines, have an increased incidence of potentially having a CLABSI occur just due to the being placed on your neck right here. It is very damp. There's a lot of folds. Sometimes the line does not stay clean, dry, and intact. With our dressing as well, patients will pick at it, hair will get into it. So just due to the physical location, puts at an increased risk of developing a central line associated event. So going back to our reviewing to our 105 module, so our eligible lines are permanent or temporary lines, which for in the dialysis space, that is our temporary dialysis lines. They have been in place for more than 2 calendar days, and remember that is calendar days, not 48 hours. And then that you have one or more one or more organisms obtained by culture with no other site infection identified. And just a reminder that when we are conducting our surveillance, making sure that we look at all possibilities of other secondary locations, that we're looking at our pneumonia definition, we're looking at our intra-abdominal infection definition, we're looking at skin, we're looking at all the other criteria before that we are naming it as central line associated event, and that we're not downgrading it from a secondary infection to a first infection, or a first infection to a secondary infection. So some key indicators that NHSM looks at specifically when monitoring CLABSIs is your temperature. So your 100, which they define as a temperature is 100.4 or Fahrenheit or 38.0 Celsius or greater. That is their definition of infection. Around your access site, it is redness, it's warmth, it's swelling, there's pain, there's radiating redness that happens. Those are some very key things to be monitoring to see if patients are meeting eligibility or if they're at increased risk of central line associated infection, or if you are concerned now and we need to be then obtaining a blood culture to confirm that yes, they do have a central line associated infection. Another thing that you can do is always educate your patient on what your line is, what it does, and kind of educate them, avoid touching, manipulating it. I know sometimes they can be very itchy, they're uncomfortable, especially with the adhesive dressing, but always if you can just have a conversation or a why of you need to leave it alone to reduce increased risk of infection, and explaining to them that we have bacteria all over our body, especially on our hands, and then when we're accessing these lines which are directly going in to our vasculature, it puts us at risk of developing infections, becoming septic, and other issues that can occur. So definitely making sure that you're explaining your why to your patients can be really beneficial and kind of help with compliance, and then also reduce of infection. So that goes into what other things can we do to prevent CLABSIs. We are aware that having this line for these patients is an increased risk factor. What are things that we can do? The first one is removing the line as soon as possible if we are done. So not just letting them kind of wait around and see. I know sometimes our providers will like to mention I don't think that they need dialysis in the next couple days, but I need to wait and see. As soon as you get that line out, the better, the safer for the patient. You're decreasing risk of infection. Or if they are going to be moved from, they're on intermittent or line dialysis, if they're going to be a chronic dialysis, then getting them scheduled for that fistula or graft, that is also really great too, since that's kind of more of a sturdier way to access and get dialysis compared to the temporary line. Always keeping your dressing site clean, dry, and intact, and changing it accordingly, and then making sure that there's good communication. In some facilities, only the hemodialysis nurses change the hemodialysis dressing. Sometimes the bedside nurses can do it. So making sure that there's not fallout of, only this person, this department changes the dressing, no, this department does. Making sure that is communicated clearly within your care team. It might not necessarily be in a policy, but it is in your facility's workflow. So definitely go ask the staff, like, who is responsible for this? Is this a standard person? Is everyone's dressing gets changed the same? I know some facilities say like every Sunday, every Tuesday, or is it when they've received dialysis? What's your workflow within your facility? And then also getting CHG bathed really helps reduce the biofilm and colonization on the skin. So definitely letting your patients know that, we need to take our CHG baths, with sometimes patients don't love them because it can leave a little bit of a stickiness to it. They might not be compliant, but definitely it goes back to what I was saying before, giving them the why, saying, why this is important, it's a safety measure, It will help keep them safe. It will decrease the risk of getting another infection, a bloodstream infection, becoming septic, kind of getting buy-in with the why. And then another thing that you can monitor is that when the staff are accessing the lines, the first step is hand hygiene, as we know is the #1 way to decrease infections and cut down on transmission. And that they are they're using good PPE with masks and gloves when accessing the line. They're also doing a scrub the hub before hooking any lines up. They're using clean and sterile gloves and maintaining sterile technique and sterile field when they're changing the dressings. And then we're also following CDC and SHEA's recommended skin preparation of our chlorhexidine or CHG for changing out our dressings and then providing those baths to our patients. And here's a great freely available audit tool from the CDC. The link is at the end of the slide deck of ways that you can go in and audit these specific practices to make sure that everything's being done appropriately, you're following best practices, and everyone's being compliant. So on this specific tool, it looks at the procedure observed, the connecting up to the dialysis or disconnecting, what discipline, so who is doing this? Is this a bedside nurse? Is this a dialysis nurse? Is this a technician? Who is specifically doing this? Is the mask being worn appropriately and properly? So making sure our mask is over our nose and mouth, nice seal around our nose, hand hygiene is performed, clean gloves, and we're changing gloves appropriately. Catheter removed aseptically, scrub the hub, as I mentioned, antiseptic, allowed to dry, so that we're making sure that we have that appropriate wet contact time to be effective, new cap attached appropriately, our gloves are removed at the end, and then hand hygiene. So this should be, you can either start from connection or disconnection and going through the steps, and then calculate your compliance within your specific observation period. Next, another thing that you can do is specifically monitor the disinfection observation of the unit. So the first audit was specifically how they're accessing and they're decreasing their risk of infection based on good practices when specifically accessing the line. But now we need to look at our environment. How clean is this environment and what can we do to improve the cleanliness by disinfecting and reducing, cross-contamination. So we want to make sure that, when you're auditing, look at your discipline. So is this EVS worker? Is this a CNA? Is this a nurse that is specifically that you're observing? Apply supplies remove all supplies from station and primary bucket. So making sure that you're taking out all the supplies and we're not overstocking. So when you have a new patient, you should be putting in new supplies, and then when patients are gone, you're removing the supplies, not just overstocking the area that you have supplies stayed between patients. So supplies for patient A should not be really used for patient B. We are removing gloves and performing hand hygiene appropriately. The station is emptied before disinfection, so we're removing all the supplies. We have our gloves. We are disinfecting the whole area with the appropriate disinfection products. So making sure that you are looking at the specific products within your area, that you are looking at the wet time and you're making sure that it says wet within that specific area for that time. Because if you're letting it dry before that specific wet contact time, you're really not disinfecting the area. So then you're putting new gloves on, you're disinfecting all applied touched surfaces, especially those high level contact surfaces. They're all wet with the specific disinfectant, as I mentioned, it's allowed to dry. Dirty gloves are removed, hand hygiene is conducted. And then no supplies or patients brought in until that this area is deemed clean, that it has good turnover, all of our supplies, and is a clean station before we start setting up for the next patient. So a great way to reduce risk is always doing prevention with education and training. So that's our CDC donning and doffing of our PPE, looking at our OSHA bloodborne pathogens, how to handle blood products, safety risks that are involved, and then knowing our disinfection products, or what time and what surfaces that we are supposed to be using them on effectively. And lastly, if you think that there is a potential issue, there's a few things that you can look at to investigate. So you can first look at your gram-positive infection, specifically in your dialysis patient population. Is this spike increased or decreased, stay the same, trended out? All water-associated gram-negative infections, if you're starting to see some of those specific water pathogens, it probably indicates that there's been a break in your water system. That your filter haven't been changed, maybe you lost pressure at a certain part and didn't notice it, that has now caused issues. That's one indication with that. If you have hepatitis B or C rates that, and HIV rates that have now increased in your cryonic dialysis patients, this indicates that there has been a bloodborne pathogen exposure. There's been high transmission of these bloodborne pathogens, and something has not been cleaned and blood products have not been handled appropriately. And then lastly, you can just go down and audit your environmental care and line accessing compliant audits. Look at your compliance rate, making sure that you're trending that out, and when you're doing audits that you're keeping track of how things are going. So looking back at the 2 audits that I showed you and their performance on it. So I know we talked about a lot of things today. Dialysis is a very complex system. There's a lot of different components that we are responsible for in very detailed specific areas, from the specific filters, their IFUs, when they should be changed, what the parameters, what they do to our environmental care, how we're accessing our lines, how we should be monitoring our patients, and our environmental cross-contamination. But if we don't do all these things, we're really setting up our patients for a specific negative outcome of producing harm to them, causing an infection based on our certain endotoxins or bacteria or other blood product viruses such as hepatitis B, C, HIV within that area if we really don't do these things. So I know this is very time consuming. It's a very unique department with a lot of risk factors, but it is crucial that we do all of these things, audit all these separate components, because that really drives us creating a safe place for our patients and for our staff. So now we're going to go into our knowledge check. You can scan the QR code here on the screen, and we're going to go through a quick 10-minute or 10-question quiz before we open it up for general questions. So has everyone logged in? We're good to move on. I'll give you a couple more seconds. Okay. So question 1. I would love if any of you can just put in your chat your answers to make this more engaging, or feel free to write out your answer. So who is responsible for the first successful treatment? Was it Graham? Was it Pop? Was it? Who do we think it is? B. Yes, that's great. I see you all in the chat. 2. What is not a component of the dialysate? Is that the bicarb, the purified water, the acetate, the iron? Yes. Awesome. Great. Yes. D. Iron. Which of the following is not a recommended practice to prevent a CLABSI? Removing lines after treatment, CHG bathing, keep sites, dressings dirty and moist, perform proper hand hygiene. Yes, it's C. Great. Keep sites always dry and clean. So dry and clean Moist leads to warm bacterial growth, which will lead to infection. And then, of course, we don't ever want our dressings to be dirty. Next, question 4. What organization provides our standards that we need to comply with? Is it AMA? Is it OSHA? Is it AMI or CMS? Yes, it's C, AMI, the Association for Advanced Medical Instruments, AMI. AMI will also do other standards, and especially anything in high-level disinfection or sterilization practices too. They have specific guidelines that we are to comply with. Question 5. What type of vascular access is associated with an increased risk? Is it your grafts, your fistulas, your ports, or your IJs? Yes, it's D, IJs. 6. What ion exchange with the sodium? Is it your calcium magnesium? Is it your potassium magnesium, sodium chloride, magnesium chloride? Yes, A, your calcium and your magnesium. Question 7, how often should be water tested? So this is the second part in your carbon filters. How often does that need to be tested? Yes, every 4 hours. Great. You guys are doing wonderful. Question 8. If there's a potential issue or you think that there's a potential issue, what should you look at? What can you go investigate? Is it your gram positive? Is it your hepatitis C, hepatitis B, HIV? Yes, that's wonderful. Correct. D, all of the above. 9, which of the following is not a typical component? Is it your water hardener filters, your UV lights, your carbon filters, or your particulate filters? Yes, that is correct. It should be A. Yes, your water hardener filters. We want water softener filters. Your UV lights can be used based on your specific system. So um, it's not a requirement, but if you're using UV lights, it's always an extra level. I mean, it's more ways to properly clean and manage the water system, and it's recommended, but they're also more costly too. So it's always that balance of doing what's best and also the cost benefits, and then getting your CFO to sign off on different things, and then specifically implementing them within your system and your filter and having them being compatible. But we don't ever use water hardener filters on any dialysis treatment. And our last question, the use of ultrafilters eliminates the need for monitoring bacterial or endotoxin testing. Yes, that is correct. It is B, it is false. Just because you have these ultrafilters or you're having the ultrafilters with a UV light for disinfection, it is still required by AMI, which is a national standard, and also the Texas regulation that I showed you, that you must conduct monthly endotoxin and bacterial testing within those specific limits. As I mentioned before, you can have a lower threshold, but those are the minimal on that chart that I showed you, that if you have levels reach or exceed that, you need to shut down your service line and conduct certain analysis. And you want to make sure within your policy what the recommended steps are at your facility. Is that, you're just moving to portable dialysis machines and you're not using the whole water system, or you're shutting down service lines? What are you exactly you're doing? So each policy will have each policy at your facility. Let me back up. Each facility will have a specific policy that says what you do in case of this emergency. So definitely make sure that you know this in case this happens, because most likely it will be Friday at 4 p.m. or over the weekend that maybe you get a call that your endotoxin testing has reached above limits, and what do you do? So you want to make sure that you are aware of your practice in case something happens, that you can speak to, okay, this is our next plan, this is what we need to do, especially that, dialysis can be considered a life-saving treatment. It is a patients need to have it done. So what are we going to do, and how are we going to provide this care during this time? Another thing, these monthly tests, they should be sent to you in the dialysis department. So every month you should be getting a copy and sitting down and reviewing it, and then also discussing it within that department, either quarterly, annually, monthly, etc. So definitely making sure that you are looking at it, and also the department, dialysis department is looking at it too, and that you're discussing it so that you can both be on the same page. If you are not getting a copy of these results, definitely go ask someone for them. You definitely are required to be knowledgeable of them. And during certain types of audits, such as when Joint Commission or CMS is there, they're going to ask you about this as well, especially if you're having an issue or if there's been an outbreak of bloodborne pathogen, of exposure, of a waterborne bacteria within your dialysis department. They're going to specifically ask you for those records to see kind of trend out where you are. Also, if you are having a huge jump in CLABSIs, this is also another way to look at to identify within your specific CLABSIs within your facility, the people that are on dialysis, and then is this due to accessing the lines and having water, and there's been a break in practices at that time too. So it's great just to be very knowledgeable about all the different components that goes into dialysis, to really ensure that we are in a facility of safety for our patients and for our staff. So here are the answers. And as I mentioned before, within a week, you will get a copy of the slide deck with today's recording of this lecture. And then we just invite you to come connect with us. So this is our email. If you have specific questions, before we open it up to the floor, you can email us at ipc@tepi.gov or at tepi.texas.gov, our general inquiries. And then also here are QR codes specifically for the other modules in our previous modules. If you've missed previous modules, they're all recorded. You can go back and register and listen to them. And then on the bottom QR code is just different resources that other corps within our TEPI organizations doing that you might find useful. So before we open it up for questions, just a quick announcement that our next lecture will be July 11th, and we're going to talk about emergency infectious diseases, specifically Mpox, CRS, H5N1. And definitely kind of go over the Texas IPU or PUIs, persons under investigation forms that the state health department has put up, and kind of, making sure that we're all on the same page with these new emerging diseases. CRS has been around, but now we're starting to see more patients within Texas have it. Mpox was just a couple of years ago, and we're seeing pockets here and there. And then the last most frequently one is our H5N1, and starting seeing that in our patient population. And then lastly, we ask you to use this QR code to complete our post-module survey. It really helps us develop better content, get topics that you all would like to hear that maybe you already need help with, or that you want more information or resources on. Based on how you fill this out, that really helps us. And then also, you'll be eligible to win some TEPI swag. If you complete this survey, you can put your name in for a drawing, and we'll mail you out some TEPI swag. So I just want to say thank you for all taking the time to listen to the lecture today. Here's the instructions for our continuing education, which this has been approved for. Just like our 204 module that you can go online, here's the steps, and you'll get this in your email sent to you within a week that you can scan or click the link to take to the site to complete these steps. And then lastly, just as an update, we've been working on some of our previous modules. If you've attended, have been approved for CE. So all of last year's modules, so our 100 series, and now we're in our 200 series, going through November, which will then be the end of our 210. It has all been approved for certified public health. Each module has been approved for 1 hour credit of continuing education, and then some of our lectures have been approved for our IPUs, for our CIC individuals, for if you are an infection preventionist and you hold your CIC, certain modules have been approved for that. Education, this one, 205 that I just presented today, is being reviewed, and we'll let you know. You should also see within a couple weeks, hopefully an email with this information as well. And then here's the link that you can go in and complete. They'll ask you kind of to go through, answer questions, do the survey, and then an email will get sent with a specific certificate that you can use when you are uploading your hours to your specific portals when you're renewing your certifications. So I just want to say thank you all, and now we're just going to open it up to questions. Okay, so we had a question from do you mean you can go lower than the minimum or not over? So yes, you can go low. When I say go lower, yes. If you, for one of the previous slides that I showed that chart on, if you want to put, instead of 50 IPU, or 50 for this slide, instead of 50 under the typical action level for your bacterial water and dilate, if you want to go to 50 CFUs per milliliter, that's fine. But you cannot over exceed the threshold, and that threshold values are these specific values. So if you want a lower level being your typical action at your facility, you are more than welcome to do that. We can always go lower, as in like a stronger response to certain things for any type of regulation. So like if there's a Joint Commission, CMS, any regulation saying your level is 5, 10, 15, say it's 15, and you want to set your standard at your facility as 10 as your actionable, your threshold limit before something happens, that's totally appropriate. It's just depending on you and your facility and what you want to do. So the next one, can you provide info on how long to scrub the hubs for certain lines? I mean, you want to make sure that you go into it. On those specific like Curious caps, if you have that you're scrubbing the hub on their IFUs specifically, it will tell you how long that specific product with that vendor, with that concentration that you should use to apply it. So on any type of medical device or disinfection equipment on the IFUs, which is a specific manual of how we use it, that long instructional list, it will tell you what the wet contact time is for it. So depending on brand that you can go in and look on that. Sometimes it's a little bit hard, like it's super tiny reading, but you can ask your vendor to surprise you with that information, your IFUs for that specific product, so that you can specifically look at. I would not recommend that being built into your specific policy, saying like, you know, that you're using brand X and therefore wet contact time should be, you know, 5 seconds, 10 seconds, 20 seconds. I would just say within your policy and how you're educating people that you are saying according to the IFUs, because in certain instances that product might be back ordered and you might have to move to another product which has a different wet contact time. Which we saw during the pandemic, that there was products back ordered due to huge need for individuals. So you want to make sure that policy wise that you are kind of protecting yourself and you're using specifically from the manufacturer what they recommend. Okay. Well, I just want to say thank you all again for attending today's lecture. We really appreciate it. If you can go complete that post-evaluation survey that really helps me develop content. And I want to make sure I'm giving you guys the topics that you need help on, that you're wanting more information. You're wanting me to find resources that are freely available so you don't have to make your own forms or audit tools. I'm here to make sure that you guys are getting what you need. And just thank you again. And just a reminder, this was recorded. Within a week, you should receive a copy of the recording along with the slide deck as well. Thank you, and I hope you all have a good day.